Right, is that coming through?
Yes, just waiting to see it in full screen mode.
There we go.
Yeah, perfect. Good.
So our final speaker in this second session is Ian Hall, talking about testing and other interventions in social care settings. Thanks, Ian.
Thanks, Julia. Hi, everyone, and apologies for not being in the room with you. Stockport, in their infinite wisdom, decide to have a 2-week half term for primary school children only. So yeah, it's sort of second week of half term here. So I've got one child in school, in secondary school, and one child here in the house with me. And she's just passed me a book she's written to read. So I'll put that on the list with student dissertation marking for later. So yeah, this talk, apologies, I sort of missed some of the first session. So I've just listened to the last 2 talks. This talk does mention testing, is going to look at some of the testing work we did, but it's going to look more broadly at some of the other interventions as well, to give sort of a more holistic view in care homes particularly. And so, yeah, some of this content you may have seen before if you've heard me talk about this in the last few months, but yeah, hopefully the slides, whilst they may be familiar, will have a slightly different slant on things. So just to set the scene a little bit, going back to either pre-pandemic or sort of the first quarter of 2020, we saw after swine flu that enclosed institutions had higher attack rates than would be expected from just random noise. So we kind of expected certain settings to be heavily sort of bear the brunt of some of this, and obviously with the additional vulnerability, care homes with hindsight were a likely hub. We did look at the cruise ships outbreaks. We looked at Diamond Princess and saw the outbreak, the sort of attack rates there were looking quite frightening if they continued on their trajectory. And we looked at the effectiveness of cocooning and how hard that might be to actually achieve, given the connectivity of care homes to the outside settings, the wider community through staff and visitors and such like. So we sort of started through February and March looking at some of these questions, and then we sort of moved, as outbreaks started to emerge, we started to look at actually analysing some of the data and forecasting from that to how many care homes might be affected. And I think sort of, yeah, it's looking at about 40% of care homes might be in outbreak status within a few months of April. Triggered some sort of alarm bells and set us up to look at this more substantively as a problem. And also there's spatial heterogeneity here. So it's not just the local pockets of outbreaks are just randomly spread. Certain areas had different temporal and spatial patterns in wave 1. We've not looked at this so much for later waves, mainly because the testing sort of got better, so we were looking at other things. But yeah, certainly the northwest and parts of Oxfordshire in the early stages seem to have more outbreaks, and that might be a sign that there were smaller care homes with shared staff in some areas, and also regional chains that could share staff between homes. And so this isn't blaming the staff for the outbreaks, it's just they're just sort of part of the sort of system, really. But it's just reflecting how not having a national social care system like we have the sort of NHS, we have a very fractured and disaggregated setting of sort of 15,000 autonomous units that have a range of infrastructures. So intervening in these settings there's no magic bullet. So just going through that timeline a little bit more through April 2020, we were starting to look at data, and we were talking with UXA and DHSE as a sort of SPI-M subgroup, really. So we had 3 or 4 members of SPI-M with on the wider group, and we set up as a social care, as a care home sort of subgroup of SPI-M. Within a couple of weeks through April, we were adopted by Full Sage. So we had we sort of scaled up, if you like, and became much more multidisciplinary. So rather than a modelling focused subgroup, we were now we had sort of clinicians and social scientists on board to give us that extra multidisciplinary underpinning to give the science advice for social care settings. And we are, for those of you not familiar with the SAGE setup, or who haven't been living and breathing it, we have the feeding into SAGE are the big 4 subgroups: NerveTag, SPI-M, SPI-B, and EMG. And then you have the sort of secondary, for want of a better phrase, but the working groups. So there's the HOKI group, hospital onset COVID group, that would have been receiving some of the advice that Stephanie was just talking about. The care homes group that I co-chaired with Charlotte Watts for a bit, then Jenny Harries, and now Eamon O'More, and then the other advisory groups that have sort of, some of these are task and finish groups, and so aren't sort of formulated all the time. And as I said, this is a multidisciplinary group, so we sort of deliberately brought in experts from COG and other settings to advise. One of our early papers was looking at data quality, and I do appreciate this is slightly divergent in some respects from a testing meeting, but I think it's important context, because in that we did do some modelling of, as well as talking about data quality, we did some preliminary modelling, and Alicia Rosello from London School she had a compartmental model for a care home outbreak, and we were able to basically say test as often as possible to minimize cases. Now that's almost common sense, and it's not necessarily helpful when we couch it like that. So we had to sort of tinge it with practical advice early on, especially when we didn't have the testing capacity we had come wave 2. I did just get a flag that my internet link was unstable, so apologies if I went a bit robotic or if I've suddenly frozen, but I'll plow on as if nothing has happened and see where that gets us. So okay, so that sort of context. Then we went through setting up sort of the monitoring and forecast, sort of surveillance systems, and sort of trying to add value to the surveillance. So we developed some forecasting systems. We looked at severity. So we were trying to monitor how the case fatality rate changes over time. And we can see that after the profound impact of vaccination, it went from a 25% case fatality rate to about 13.5%, and is now sitting at a fairly stable 6%, although maybe the denominator is a little bit wonky now with testing as it is. But it's a fairly, it's yeah, sort of the impact of Omicron seems to have come through there. And then we had, and this certainly comes back to the sort of some of the challenges around testing, even though it's looking at another aspect, is in autumn 2020, we were asked what we thought about allowing visitors back. Visitors had been barred from many care homes through the wave 1 because of testing because of the dangers of bringing the disease in. But there's the residents were starting to feel isolated, or were feeling isolated, and so there was a benefit to allowing visitors. And so we had to do a trade-off, and we brought in a health economist, Alex Thompson, who was able to sort of bring up, sort of look at this harm trade-off and improve upon my sort of fudgy cost-benefit analysis to look at the harms of a disease outbreak compared with the impact of isolation. And so we were able to get some measures of the quality impacts of isolation, but it's not, this is a really understudied area. And so it's very hard to look at these sort of what might be thought of as softer impacts, but are really important impacts of the interventions around isolation, and we'll hear in a minute about care provision if staff are absent. So we really do need to come up and improve the frameworks we use to analyze these systems to sort of balance these harms more equitably, and that will be hard and take quite a lot of further research, I imagine. But there's, yeah, I mean, rather than qualities, maybe there's these ASCOT tools and things that are trying to measure these systems. And the other thing that we looked at was also around what are we trying to do with these interventions? What is the hazard that is trying to be mitigated? And this enables us to say why care homes are special compared to, say, a hospital, which argue, because one of the points we had to discuss was, why don't social care staff just have the same testing regime as hospital staff? And so we came up with this hazard profiling sort of system for there's a disease ingress hazard. These settings are connected to the community, and this setting could be a prison, it could be a care home, it could be a hospital. And there's some flux between them and the community that brings the disease in. And then once it's in that setting, there's a transmission risk. For a care home, those contacts are requiring care, so they're close contact. Then there's the outbreak risk, a hazard, that because there's a large pool of susceptible people potentially. Some of these care homes got up to about 200 people. The average size is about 30, so they're bigger than a hospital ward, smaller than a hospital, but bigger than a hospital ward. And so that outbreak potential is sort of real, certainly in wave 2 pre-vaccine. And these residents are highly vulnerable due to their frailty, their comorbidities, and their age. And so taking that in sort of together, then we sort of felt as a group that there was a warrant, there was a sort of question that you could have a more stringent testing regime, say, on staff than for healthcare workers more generally. That's happy to discuss that, but that was the framework that we came up with there, and we've applied this also to hospitals. Eamon O'More on the UXA side of things is also the UKHSA lead for justice health or prison health, so he's been able to translate this to the prison setting. The interventions in place are quite complex and multifaceted. The only one that cuts across all of those hazards, all 4 of those hazards, is vaccination, because it reduces the ingress risk by having less disease in the community. It potentially reduces transmission, although maybe not as much as we hoped. It composite of having lots of vaccinated people reduces the potential for outbreaks. And as we saw before, it halved the case fatality rate, so it improves outcome. And so yeah, that is a special intervention, but it's not a magic bullet. You can't just rely on vaccination alone, in the same way that we can't just rely on testing alone. So let's come to the sort of meat of this, I guess, and for a testing workshop, let's look at what we did for testing. We brought in, we developed a model for the viral load over time, and this model is really Carl's, and so Carl in the room with you is probably you want to pester him over coffee or something if you want more details. But we were able to develop this viral load model, in-host model, and then play various scenarios about that a person being detected by a given strategy, and work out what the reduction in infectious potential was for different compliance rates, assumed compliance rates. So we assumed 70% because that was the value that seemed to come out of some of the DHSC operational analysis on care home staff uptake. And then the 40% was a lower bound for staff uptake in a different sector. I won't tell you what that sector was, but that was just a lower bound on compliance. And that sector then had mandation of testing thrust upon it because its adherence was so low. So there is, but they are informed parameter values in some respect. We can maybe quibble over the details of those, of how we derived that 70%, given the timing of interventions and such like, but they're plausible, credible numbers. And so we can start to see that if you test every day, you might get half a day of someone being infectious in the setting, rather than one and sort of 0.6 or whatever it is. So you can see there's this reduction in infectious potential. And then we can look at adherence slightly more carefully. So this is sort of it's probably a slightly different graph of the one we saw before, but we can look at the impact of the frequency of testing with the adherence. Now, the adherence here was a relatively simple assumption that people just randomly, spontaneously decide to test or not. And I think behavior is really important here because it depends on what assumption. This is a structural model in the assumption in the model that we're assuming. If we assume that people are, I mean, modelers in the room will probably sort of recognize this from discussions about vaccination as well, about leaky or all or nothing. But you could have some people in the population that are just obstinate and bloody minded and don't do the testing, or you've got people that just forget. And in reality, it's going to be some complex mix of both. Possibly at an individual level, people will be maybe change over time. But we can sort of do some sensitivity there to look at the difference between all or nothing or leaky, and just assume that everyone does that, or that is applied to the whole population, expecting some smoothing out in reality. And it does make a difference, these assumptions. All or nothing kind of erode some of the benefit, but is yeah. So I think further behavioural work, behavioural science underpinning on this is something that needs further consideration as we go forward. It's certainly the structural assumptions in the model need to be sort of thought about, even if we can't parameterize it to the nth degree. And we've taken this further slightly in that we've done some work with Protect. We've got a PDRA on Protect who's developed an in-host model, in adapting rather than this piecewise linear exponential model that Carl used. We've tried to use an ODE-based approach. And I don't have time here to sort of go into the details of that, but it's inspired by a paper that was written by Goyle last year. And yeah, we can fit to that and get similar fits, and indeed get very similar fits to the piecewise exponential. So the assumptions we make in the in-host model could also be important, especially if we're looking at longer term behavior. I mean, obviously here we're looking at LFDs predominantly, And so it is a sort of shortish window of time. So maybe that's less of an issue, but something to think about, I think. I will skip over these, I think, in the interest of time. I'm conscious that it's one, but there is a connection, a correlation with the ONS prevalence positivity, and that's changed over time. I think Stephanie was just saying that healthcare workers were twice at risk as the community, general community. That was true in social care workers in wave 2 pre-vaccination. After vaccination, that may have flipped actually to being half as at risk, but then over through Omicron, certainly that's come back to parity. So there is this complex changing over time of the risk from the community to these settings. And then coming to the impact, can we evaluate the impact of these interventions on social care settings? Well, we can look at the average number of cases per outbreak over time, and that's reduced or changed. And through post-vaccination, that's been fairly stable at about 5 people with maybe 3 residents. But there's also been a change in the number of resident-only outbreaks. Now, the conjecture there being that, staff-only outbreaks. The conjecture there being that staff-only outbreaks are somehow being mitigated by these interventions, and so limited by these interventions, predominantly testing. And so we can say if those outbreaks had continued to the same size as the other outbreaks, then we're looking at the interventions as a bucket, reducing 12,000 or saving 12,000 or averting 12,000 deaths, perhaps. It's harder to say that's all because of testing, but it's one way of evaluating these, and we're still making sure that's sort of a robust number. We're working through that, and we've got a meeting on Friday with UXA colleagues to go over some of that again. So I will wrap up there. I think for social care or care homes in particular, the data was weak. It is weak. There are no social care episode statistics like we would have hospital episode statistics, and so it's very hard to know who's in a care home and stuff. We know where the care homes are, but we don't necessarily know a lot about these things, and the beds reported are possibly not a great proxy for who's in there. So there's a lot of improvement in data that can go on in the future. I think one of the key gaps, as well as for the testing work, is around the impact of care, staff absence, and what impact that has on care provision. We don't know. We just don't know whether that, I mean, that's probably not linear, because they can probably fix a few staff being absent, but then they'll hit some threshold where it's catastrophic and they can't provide the care that they need. And so how do we measure that, and how do we model that? So there's a lot of sort of future work that's sort of needed here to look at this in more general. And I've spoken mainly around testing of staff and testing of visitors. I haven't focused on testing residents. You may think that's a little bit strange, but actually the residents are very frail. And so ethically, the clinicians on the group felt that we couldn't really advise that you just test frail residents every day or even every week. It just wouldn't be ethical, even though they're at high risk. So we had to make that compromise quite reasonably, and just focus on staff testing. We did introduce a monthly resident screen, so residents were tested once a month just to check, but that didn't. After checking on that, it didn't really pick up any extra outbreaks or meaningful outbreaks. And they didn't implement that in Scotland, and Scotland didn't have a better or worse outcome than we did. So I don't think testing residents was critical, or not testing residents was critical. It is really the staff getting it at the front door important there. And I will end there with the acknowledgements for this, and stop and see if there's any questions from the room. So thank you for listening.
All right, thanks, Ian. I'm going to pass the microphone. If you can't hear, can you shout or wave or something?
Thanks, Ian. You talked about testing, potentially preventing 12,000 deaths. To what extent do you think the deaths are attributable versus incidental deaths? You know, because that's one of the things that we're thinking about with hospitals, that it's a very, very difficult thing to figure out. It's the same with the length of stay. Obviously, that's not an issue for care homes.
Yeah, no, I think that's that's a really a good question, a very hard question, because the average residency time in a care home is sort of a couple of years, I think, and so these people are frail. They're frail without COVID. They're not going to be there forever, and so what, using excess deaths as a measure isn't a good measure anymore. And so yeah, that 12,000 does need to be heavily caveated in that, obviously, if people may have died in the meantime, and I think that's why I'm a little bit cautious of going too hard on that number until we've thought through some of these ramifications. But it's I think in terms of attributed to COVID, I think that's a little bit clearer, because CQC, there's a legal mandation for care homes to report their deaths to CQC, and since the 10th of April 2020, they've been coding that by confirmed or suspected COVID. And that's got better over time, and now is a fairly reliable measure. And so I think that what I mean by that is attributed deaths to COVID. There hasn't been, in the baseline mortality, if you look at non-COVID deaths, that's been pretty flat. There's been no real seasonality or deviations from random noise in that signal since 2020. So there isn't really a major sign of periodic increases in mortality not attributed to COVID. So yeah, I think there is, through Omicron, there is a little bit of departure from the UXA line list to the CQC list, and that's being investigated. So yeah, but yeah, I don't quite know if that completely answers your question, Steph, but I think it's, hopefully it waffled around the area.
No, thanks, Ian. I think we're all very interested to hear what happens with this 12,000 figure, and how that stands up to further analysis. It's I'm not going to take any further questions. We're 10 minutes over. It's my terrible chairing, sorry. Ian, thank you very much, and I hope you have a lovely rest of half term. And let's just thank all the speakers again before lunch.
Thank you, Julia, for chairing. Just to say, so